Good morning, colleagues. To those of you face-to-face as well as online, welcome to day 2. My name is Wade Douglas. I'm from the Human Movement Science Department, and I will be your session chair for the first session. All right. Colleagues online, can you just by a show of hands indicate that you can hear me clearly? Okay, I'll take that as a yes. Thank you so much. So just to stick to the program, first on our list will be just a short welcome from Prof. Melariri. And I will hand over to Prof.
Good morning and welcome to day 2 of the Research Week. I hope we had a thought-provoking and inspiring day 1. And I'm sure that today we have a good lineup of activities, presentations that will further enable us to push boundaries and get to that target we desire. It's important, colleagues, that we maximize this opportunity and really celebrate curiosity, celebrate creativity, celebrate collaboration, which is actually the intent of having a research week such as this. So please, just to say thank you so much for your inputs, because that you're here means you really made frantic efforts to carry out some research and also to even listen to others, even if you're not presenting. So it's exciting to see you both on site and online delegates. And to our able chair, thanks for being on time, and thanks for the vibes that we're going to have in this particular session. I'm sure it will not allow anyone to sleep. So please, let's just grab the tea when it arrives and make sure you relax and engage. Celebrate the curiosity that colleagues have actually put in to ensure that they have the results they're sharing with us today. So thank you so much and enjoy the day.
Thank you so much, Prof. Just a couple of house rules to the presenters. Let's try and stick to the program. We're going to have 15 minutes to present and 5-minute open Q&A, and I will control by virtue of time cards. And for those online, if you can't see the time card or you aren't, acknowledging the time card, you will force me to jump in, and I will have to ask you politely to stop your presentation so that we could just respect all the other presenters today. First up, we're going to have Dr. Amadila, and she's going to look at exploring the views of selected and unafflicted women from Walvis Bay and Windhoek, Namibia, regarding intimate partner killing and its effect on their well-being. Doctor, we're going to give you about 30 seconds just for the presentation to reflect on your side, and then you can carry on.
May I start?
Yes, you may, Doc.
Okay, a very warm good morning to all the delegates present and physical and online this morning. I would like to also acknowledge our Director for Research, Prof. Melariri's hard work and effort to pull this off this well with Ms. Berthlin, and also to our chairperson, Mr. Douglas. I am ready to start.
Doc, you may start.
Okay. My topic is on the research topic that I did based on my PhD was exploring the views of selected and afflicted women from Walvis Bay and Windhoek, Namibia, regarding intimate partner killing and its effects on their well-being. The research findings to be presented here are purely from audio records of women from Walvis Bay and Windhoek who volunteered to share their knowledge and information about the phenomenon of intimate partner killing. Policymakers and the health sectors can use these views and opinions to help women deal with the trauma of intimate partner killing incidents, which they have to live with daily. Next. Findings. The findings to be presented are based on the study's objectives. As with any scientific research, establish factors in a phenomenon. This presentation has a summary of findings following the conclusion of the interviews aimed at providing evidence of the views of selected unafflicted women from Walvis Bay and Windhoek in Namibia regarding intimate partner killing incidents and its effect on their well-being. Okay, we are going to start with the findings from the first objective, which was the views and the descriptions of unafflicted women regarding incidents of intimate partner killing in Namibia. Now, themes were grouped or categorized based on the codes that were identified. And we are going to discuss 4 themes under the first object, and we are going to discuss 3 themes under the first objective, which is possessiveness, jealousy, and social pressure. Now, under possessiveness, we had a sub-theme, which was obsession. Based on the answers provided by participants, women are murdered due to reasons such as men having financially supporting the woman, and once the women are above the poverty curve, they try to end the intimate relationship with the provider. In addition, participants identified contributions towards intimate partner killing by women in which a woman may provoke a man to the extent of hurting her. The second theme is jealousy. Jealousy had a sub-theme, which was obsession. Now, under this theme, obsession caused by jealousy, where a man cannot accept that the intimate partner is intimately involved with another man. Now, the intimate partner ending the relationship for the material reasons, where a man spent money to support a woman from a poor background, like we spoke previously, that a man would...
Sorry, Doc, we have lost you there for a brief second.
Okay.
Doc, are you still there?
Yes, I am here. Can you hear me, Mr. Douglas?
Colleagues online, to those of you face-to-face, just take 1 minute until we just sort out this glitch. These things happen with technology.
Sooks, can you hear me?
Yes.
I'm testing with the venue. Just a second. Sooks, can you hear me? Okay. 1, 2, 1, 2. Can you hear me? Yeah, but if Sooks, can you hear me? 1, 2, 1, 2. Sound check. Check the channels on the Teams if it's on Roadcaster chat. Yes, Sooks knows with 1, 2, 1, 2. Sound check. 1, 2, 1, 2. Sound check. 1, 2, 1, 2.
Testing.
1, 2, 1, 2.
Bill, can you hear us now?
I can hear you. Can you hear me?
Yes, I can hear you.
Okay, perfect.
Okay.
Sorry
Doc,
about
can
that.
you hear us?
Yes. Yes, can you hear
Dr.
me?
Madila, can you hear us?
Yes, I can.
Ah, perfect.
Okay, perfect. The sound is back. Okay.
Doc, apologies for the glitch. You can carry on where you left off.
Okay, thank you so much. As I was busy with the second identified theme, which is jealousy, and I say that obsession caused by jealousy, where a man cannot accept that the intimate partner is intimately involved with other men, the intimate partner then ending the relationship. Now, for material reasons, where a man spends money to support a woman from a poor background, relaxed laws where the government is not doing anything or enough to amend the constitution, and introduce stricter law for intimate partner perpetrators specifically, and the evil society and cultural differences are some of the causes of intimate partner killing identified by participants. The third theme and the last theme under the specific objective is social pressure. Now, the study found that women tend Can you hear me?
Doc, we can hear you.
Okay, we are moving on to the third theme, which is social pressure. Now, social pressure as the last theme under the objective states that the study found that women tend to get partners for material gain, and in most cases, not love. Now, intimate partner killing incidents affect unafflicted women's decisions and choices of having future relationships because they feel they cannot change or improve their surroundings. We move on to the findings of the risk factors regarding intimate partner killing incidents, views of unafflicted women in Namibia, which was the second objective. Now, under the findings of the risk factors, we have the identified themes, which is infidelity and financial support and escalation, alcohol and substance abuse, emotional regulation. So we are going to start with infidelity as a theme. Now, the sub-themes under infidelity, the main sub-theme is cheating. Among the causes of murders of women by their intimate partners is sexual infidelity. This means that one's reactions, like having sexual affairs with other people besides the intimate partner, will affect how the intimate partner will treat the partner they are in an intimate relationship with. This is evident when the intimate partner murders his or her intimate partner. Infidelity as a personality factor affecting the psychological well-being of women and men, and it is recognized in interpersonal relationships. The second theme is the financial support. The sub-theme identified here was poverty. Now, in most cases, the woman killed had been with the male intimate partner who provided for her and sometimes even sacrificed to pay for her education. This is common in Namibia as many women travel from rural areas for better lives. Now, poverty in most cases, as revealed in the data collected, leads to cheating, and cheating leads to intimate partner killing. The third theme is escalating alcohol and substance abuse. Okay, now the study found that alcohol and drug abuse contributes to the intimate partner killings of women by their partners. And the third is emotional regulation. And they say that after participants provided their views regarding risk factors contributing to intimate partner killing, male short-temperedness and male low self-esteem, which could be triggered by females showing off new partners, are some of the identified risk factors leading to intimate partner killings in Namibia. Then we move on to the findings on the description of the incidents of intimate partner killing that unafflicted women in Namibia are aware of. Now, intimate partner killing strategic planning is the main theme. The study responses indicate that there are different ways in which men kill their intimate partners. Participants were asked to mention one harrowing incident of intimate partner killing and explain how women were killed. Now, according to the findings, perpetrators slit open the victim's throat, stabbed victims with knives, used a panga to behead their victims, used a gun, and shoot them or hit them with unidentified objects. The second theme identified was weapons used in intimate partner killing. Participants mentioned cases in which women were killed with knives. According to the answers provided by participants, knives were commonly used to as weapons in the gruesome incidents described by the victims. In the next most commonly used weapons were firearms, pangas, and some participants also mentioned strangling and using unidentified objects to end women's lives. The third and the last theme under this category was the age range of victims. Participants were asked which age range, according to the incident they have heard of, were likely to be victims of intimate partner killing. All participants' answers suggested that intimate partner killing mostly happens between or women that are younger. Now, as they are the ones who are struggling to become financially independent, others said women with young children who are still in intimate relationships with their fathers are likely to fall victims of intimate partner killing. Some said intimate partner killing victims are primarily young adults or women between the ages of 30 to 45. The findings of unafflicted women's views on how intimate partner killing incidents affect their well-being. The identified theme was unsafe. The sub-theme is scared. Now, participants said they felt unsafe at the significant news about intimate partner killing and constantly repeated the exact phrases regarding feeling unsafe. Statements by participants reflect a combination or a complexity of anxiety-related mental ill health, in which an individual, due to the adverse events, tends to focus on the possibility of uncontrollable danger or misfortune. The second theme identified was fear. Participants each referred to the future with the worry that they might be next. In generalized anxiety, the most common sign shown by all participants is difficulty controlling feelings of worry, restlessness, and wound up and on edge. Now, signs observed in participants were those of fear of being the next victim, which led to feelings of being out of control. The third theme is traumatized. Participants explained and described how incidents of intimate partner killing made them feel. It was evident that to a certain extent, intimate partner killing is a traumatic event and can cause anxiety like fear, phobia, and post-traumatic stress in women who may learn of the incidents from different social media platforms. Okay, this is also called vicarious trauma. It can also be experienced by members of the general public who may be informed of the latest incidents through televisions, newspapers, and social media. And the last is scared. Now, scared participants reported an inability to control their worry, employing coping strategies when it came to intimate partner killing incidents, in which made them scared. Now, specific phobia distinguished in fear or anxiety specific to an object or a situation, and the amount of fear and anxiety related to the specific object or situation, like incidents of intimate partner killing. In the case of this study, intimate partner killing incidents reported in Namibia caused participants to experience anxiety, fear, and stress. Now, this study is of the view that how people react to similar traumatic experiences may vary from one person to another depending on environmental, social, and cultural factors and individual biological vulnerabilities. The findings are based on the views and opinions of participants of the intimate partner killing phenomenon, that intimate partner killing incidents have effect on the well-being of women and pose a mental health threat to their overall well-being. Each time women hear of intimate partner killing incidents, they become scared at the thought of being the next victim. This brings me to the end of my presentation, and I would like to thank you all.
Thanks for the presentation, Dr. Madilla. I'm going to allow questions on the floor first, and once we've dealt with those, I will open the questions to colleagues online.
Thank you. Morning, Doctor. I just have a few questions with regards to the methodology. In terms of the participants, not sure if you've mentioned how were they recruited, and in terms of retelling the trauma of the victims, were they given the option of critical incident debriefing? In terms of the findings, I also wanted to find, just to establish, do you think that with men being the perpetrators and poverty playing a huge role in intimate partner violence, do you think that a patriarchal society or institutional or discrimination against women would also play a role in terms of IPV?
Thank you very much to the questions. Let me start with the methodology. Okay, the study it was a qualitative study where we used semi-structured interviews. Now, women were selected purposively as we were having strict inclusion and exclusion criteria, looking at the fact that the study was also rated as a high-risk study where it was carried outside the university, and we had to make arrangements for psychological counselors, where we had to make sure that now to avoid or to adhere to the REC's recommendations, we had to make sure that women that were interviewed, as we said, purposively, meaning that these specific women were not supposed to be the family members, next of kin, friends, close relatives to any person or any woman that was murdered, to avoid the severe trauma. Okay. Secondly, or let me answer the next, or let me go to the findings, and then maybe you can help me refresh back to the middle question. Now, the findings, indeed, if you look at the theoretical framework, we talked about feminism, patriarchy, and we talked about the theory on the systems, the system of the community, where we say that obviously patriarchy, society, and feminism all have specific contributions to the killing of women, because most of our men, according to the participants, stated that they are raised in a background where a man should show that he's a man, for instance, or a man should be a provider, where they do not feel that it is a problem to support or to take in a female who came from a rural area background to the city in search of employment, or to attempt to study at a certain specific institution. As the participants also mentioned cases where it was specific students that were murdered. Either the student was dating a taxi driver, or the student was dating a bus driver from those who commute long journeys or long distances. What was the next question that I've omitted?
I think you alluded to the patriarchy and then institutional discrimination against women using the framework of feminism, obviously.
Doc, did you get that question?
Okay. Can she repeat? There was a hiccup.
No problem. We'll repeat the question, and that will be the last question, unfortunately. And Doc, I'm going to give you 2 minutes to answer that question, please.
Okay, thank you.
Institutional discrimination, do you think that that is also a factor in IPV?
Is institutional discriminations now, which specific institutions, or is it the Constitution?
In terms of accessing services, for example, when it comes to GBV or IPV, institutional discrimination also plays a role, for example, and I'm just saying in terms of men getting paid more, for example, or having access to services more than women, if that makes sense.
Okay, no, I get it. Thank you so much. Currently, at the moment, maybe it's also a similar practice in South Africa. We have revised the Labor Act, where they say that it's reverse discrimination, where we have affirmative action. Now, affirmative action favors women. Say, for instance, if Mr. Douglas and I sit for an interview, and Mr. Douglas scores 90% and I score 82, I'll be given preferential treatment over the position. Meaning I feel that the institutions are trying to move away, from the feminism patriarchy where women had to sit at home. In Namibia, it's no longer the practice. Most women, as you can see, they say that in Namibia, it's where it was rated that it's one of the few countries where most women, or even on the parliament, the majority is women. So therefore, I feel that it could be, but it was not really raised by the participants. Therefore, institutional-wise, I feel that because even the looking at the health sectors, the police services, they put in place departments or divisions where women should feel free to come out. Things like restriction orders, even if unfortunately, there is not a specific law for punishing perpetrators of intimate partner killing. That's what participants want the institution or the government to consider, that beside all the other methods that they are trying to make women come out on top and not be the object or feel subjected to poverty. Thank you so much.
Thank you so much, Doc. Appreciate how you addressed all the questions, and to the floor, thank you for the question as well. Guys, just an opportunity to thank the speaker. If you have any more questions, feel free to direct them directly to the doctor, and you guys can take that conversation on a different platform. Thank you so much.
Thank you very much.
Okay, colleagues, we move on to the next speaker, Ms. Ferre. I'm going to give you 1 minute to set yourself up, and then I will introduce your topic, and then you can take the floor away.
Now
Colleagues, for the sake of time, I'm going to try and stick to the program. So Ms. Ferreira is going to look at the prevalence, risk factors, and diagnostic biomarkers associated with. Wow. Gotta help me out here. Oh, schistosomiasis transmission among school-going children in Nelson Mandela Bay. That was a tongue twister there, just to wake everybody up. Enjoy the presentation.
Thank you so much, everyone. Good morning. My name is Marilyn Ferre, and I'm a PhD student in the Environmental Health Department. I'll be talking about my research project. Thank you. I was focusing on the prevalence, the associated risk factors, and diagnostic biomarkers that are associated with schistosomiasis infections among school-going children in Nelson Mandela Bay municipality. Okay, thank you. So I'll quickly go through my slides. I have quite a number of results to present and a very limited time to present all of them. So the focus of our study was mainly to determine the prevalence of schistosomiasis, but we also focused on determining the prevalence of soil-transmitted helminthiasis, as these two neglected tropical diseases usually coexist in the same geographical regions, and the risk factors that are associated with their transmissions, they are usually the same. And I'm going to take you through an introduction of schistosomiasis, what it is, and the STH also, to just show you a picture of why we did the project. And I'll take you through the methodology and the results that we got from our study. So schistosomiasis is a parasitic infection that is actually caused by blood flukes that dwell in the blood. They're blood sucking. And when they infect humans, they can actually dwell in intestines or bladder for 40 years. So this is a devastating disease. And I'll mostly focus on S. hematobium and S. mansoni, as these two species are the ones that are mostly prevalent in South Africa. So S. hematobium causes urogenital schistosomiasis. They dwell in the bladder and they cause pathological effects in the bladder there. And for S. mansoni, it's an intestinal parasite that dwells in the intestines and the blood sac and cause devastating pathologies in there too. So for treatment, most of the countries in Africa, they have treatment programs for schistosomiasis. Unfortunately, in South Africa, we currently do not have a national control program for schistosomiasis. But however, praziquantel is available to treat schistosomiasis. So the the age group that is mostly affected by schistosomiasis is the children who are between 5 to 19 years old. Why? They have a higher frequent contact with water bodies. We're saying they go to fish, swim, mostly compared to the other demographics, especially in areas with higher prevalences. And the most endemic provinces in South Africa includes the Limpopo province, Mpumalanga, KwaZulu-Natal. There has been ongoing endemicity, however, in the Eastern Cape province, with other imported cases reported in the Western Cape. So, like I said, there have not yet been national control programs yet in South Africa. Sorry. So I'll take you through the life cycle of schistosomiasis just to show you how the parasite grows and develops in the humans and in the snails. So I'll divide the life cycle into two. The definitive host, which is the humans, is also zoonotic. It can occur in animals, and the intermediate host, which is the snails. So we're saying if a person is infected with schistosoma secari, which is the infective stage of the parasite, it gets into the person through the skin and it loses its tail. When it loses its tail, it transforms into schistosomula. This schistosomula migrates in circulation to the lungs, and then it's taken into the liver, where it then matures into adult female and male worms And these adult female and male worms are then transported to intestines in the case of intestinal schistosomiasis, and they're transported into the bladder in the case of urogenital schistosomiasis. The female worm will actually lay eggs up to 300 eggs per day in terms of high endemicity. But however, we're saying in Nelson Mandela Bay, due to the retrospective data that we got, there are low infection intensity cases that have been reported. So instead of the 300 eggs that are laid per day, they actually experience low egg production rate per day, which means that these eggs may not actually be even produced in a day. So when we do the diagnostics, we may not even detect these eggs. When the eggs are excreted from the body through the urine or stool, they then come in contact with water bodies. We're saying if a person defecates or urinates in water, they hatch into miracidia. The miracidia is the infective stage for the intermediate host, and they then multiply in the intermediate host to form cecari, and the life cycle goes on again. So for soil-transmitted helminthiasis, we have quite a number of species that cause soil-transmitted helminthiasis, from roundworm, whipworm, and hookworm. I'm sorry, I'll go on quickly. I have a lot of slides. And it's also prevalent in children of the same age group and is treated using albendazole. So in South Africa, reports have been reported to the regional prevalence of schistosomiasis has been reported to extend from the Limpopo province down to Port St. John's and Port Elizabeth. And there have been national deworming programs in 2016 that actually yielded good results to reduce the prevalence of soil-transmitted helminthiasis. So the life cycle, I'll focus on Ascaris lumbricoides because every soil-transmitted helminthiasis sort of have a different life cycle, but for the purpose of this presentation, I'll only focus on Ascaris lumbricoides. We are saying that if a person is infected with the eggs, they migrate into the lungs where they also mature, and they dwell also in the intestines where they can live in there for years. And we are saying that when they mature into male and female worms, the female worm also lay eggs, and these eggs have to come into contact with soil. So we are saying when they come into contact with soil, they complete their life cycle because these eggs would now hatch into an infective form of the parasite. So we are saying that there is a low prevalence of schistosomiasis and STH in Nelson Mandela Bay, but it's there. It's the transmission of schistosomiasis and STH is there. So we wanted to determine what exactly is the prevalence of schistosomiasis and what is the intensity of infection that is going on in Nelson Mandela Bay. We also wanted to see what are the risk factors that are noted to be causing the transmission of schistosomiasis, because when an infected person pees or urinates in a water body and another child comes and swims in the same water body, they can get infection. So we wanted to see what exactly is causing the transmission of schistosomiasis, and we also wanted to see the diagnostic biomarkers and that are involved in schistosomiasis morbidities, so that we can see if we can develop a test that can focus on diagnosing schistosomiasis in low transmission areas. So our objectives, I have tried to group them into two. For the first stage, we're determining the prevalence and intensity of schistosomiasis and STH infection. Then we profiled biomarkers of schistosomiasis in the samples, in other samples, but we wanted to compare them with positive samples we wanted to profile the biomarkers that were in positive samples for S-hematobium infections so that we can sort of determine which ones are mostly associated with schistosoma infections. Then we also did a POC-CCA test. This is a point of care circulating cathodic antigen test that tests for active S-Mansoni infections so that we can see if there is any S-Mansoni infections present. Then we did a PCR test. So this is a molecular method that is actually used to detect schistosoma DNA in samples. It's more specific, it's highly sensitive because it detects actually minute DNA levels in a sample. So it's more sensitive than the POC-CCA and detection of schistosoma ova in samples. Then lastly, we wanted to assess the knowledge, attitudes, and practices, and the risk factors that are associated with schistosomiasis transmission, so that we can come up with a conclusion to say there is schistosomiasis and there are also risk factors present to transmit schistosomiasis. Okay, so we got permission from Wreckage. We approached 15 schools, and we got parental and learner consent from parents, and our study participants were children who were aged 5 to 14 years. And our study area was the whole of Nelson Mandela Bay, but we managed to only sample five towns, which are many towns actually, and we managed to sample 15 schools out of those 5 towns. And the majority of the schools we sampled were in KwaNobuhle. Why? There are so many rivers and ponds that span the area, so we assume that if there is any transmission occurring, it occurs in an area where there are many rivers, since that's where the transmission occurs. So our study was a quantitative descriptive cross-sectional study. I will not go back into the inclusion and exclusion criteria. That was our data analysis. I want to come to here. Okay, so this diagram gives us a summary of our study. So our total sample size was 759 participants. So we wanted to diagnose S. hematobium in the S. mansoni, sorry. So for S. hematobium, we use urine filtration. This is a technique that is used to detect any ova, which are eggs, S. hematobium eggs, in urine. So it filters the urine, and then we can look on the microscope to see if there are any eggs. And we actually found 1 positive sample out of the 759. Then S. hematobium also has also been known to be represented by hematuria. Hematuria is blood in urine. It's a proxy for S. hematobium, because you're seeing if the S. hematobium are dwelling in the bladder, they can actually cause ulcerations in the bladder, leading to the production of hematuria. So we found 255 samples that were positive for hematuria. For S. mansoni diagnostic, the Ketrocast technique is also used to detect if there are any S. mansoni ova in stool samples. So we found no positive samples after Ketrocast, and the POC-CCA test diagnoses the CCA biomarker, which is a circulating cathodic antigen biomarkers that is linked to active infections of S. mansoni. So this test actually gave us a clue that there is intensity and positivity and prevalence of schistosomiasis in Nelson Mandela, because we can actually see that there are 28 positive cases here and 23 were traced, showing that it's there, but occurring at a very low intensity that could be determined by trace. So what we did is we then went on to do a PCR on these samples that had initially tested positive for POCCA, to confirm if we can detect S. mansoni DNA in these samples using this primer. Then we found out that 9 samples were actually positive for S. mansoni, which gives us a 32.1%, but relative to the only to the number of samples that we tested, which were 28. Then we also did the same with S. hematobia. For the 255 samples that we found positive of hematuria, we wanted to confirm if there is actually S. hematobium DNA in these samples. And out of them, we chose only the samples that were showing macrohematuria, which were 122, and 1 positive sample. Then we also ran those on PCR, and we actually found out that there was 31% prevalence of schistosomiasis using this primer, and there was 51.6% prevalence using this primer, and 50.8 prevalence using this primer. So the results that we got can actually show us that although in low intensity, schistosomiasis is present in Nelson Mandela Bay, but we need to use a more specific and highly sensitive diagnostic to determine and detect infections, because these tests that actually diagnose eggs cannot be as sensitive due to the low egg extrusion rate, like I said earlier. So we tested for biomarkers. We wanted to see and sample the biomarkers that are present in all the children. And at the end, we wanted to relate them to the infected participants. We found out that the leukocytes, nitrates, urobilinogen protein, and blood, these were recorded in the literature already to be associated with schistosoma infections. And we can see that the positive ones highlighted, shown in blue, are actually present, showing that there are also infections of schistosomiasis occurring in the study area. So I'll skip this. It's a repetition of what I said. Then we wanted to see if there are risk factors that are associated with schistosoma transmission so that we can come up with a conclusion to join the two. And we found out that, yes, there are risk factors that are actually associated with schistosomiasis. Like the school-going children we interviewed actually told us that they cross rivers on the way to school, and some of them actually do it barefooted. And some of them who are living in informal settlements, they actually use bush toilets and they live close to the rivers, and some urinate even while swimming, and they go swimming and do fishing, which actually supports our results to show that there are risk factors that are associated with schistosomiasis transmission. Then we went on to assess the knowledge, attitudes, and practices that are related to schistosomiasis among the learners. But I'll just summarize and say that we found a positive association between knowledge and attitudes, but between the other variables, we could not establish an association. So this is just a summary of what I said earlier. I will not go into it. And the strength of our study was, it gave us a comprehensive diagnostic approach to actually use so many diagnostic tools to try and detect the prevalence of schistosomiasis. And we actually got a picture of what it looks like. The use of PCR actually helped us because it can differentiate between true positives and false negatives. And we integrated the questionnaire to show us the risk factors and okay, that's repetition. So I would also like to thank the Water Research Commission of South Africa for funding the project. And thank you so much for listening.
Thank you so much, Ms. Ferrer. You were a little bit under pressure with time, so you were rushing towards the end, but thank you so much for your presentation. Colleagues, I'm going to change it up a little bit. I want to give the delegates online a chance to ask a question because we didn't get to you with the previous speaker. So is there anybody online that wants to direct a question at Ms. Ferrer? Please feel free to unmute yourself. I won't be controlling the mute and unmute.
Okay, thank you. Can I come first?
Yes, you may.
Okay, this is Professor Taka Duluza. Even though I'm so much interested in Ms. Ferrer's work, I've been working with the WHO, and I see a lot of interest and a lot of projections, which sends a lot of warning signs at the Nelson Mandela Bay. Even though the infection is very low, but the results are showing that there is a sort of some transmission which is going on. What I just want a verification from the presenter is what are sort of like preventive methods or approaches that the Bay are taking so that they can prevent, because it starts as a small flame and then grows into a big flame. It's prevention, which is very important because it shows the transmission is taking place at that location. Thank you.
Thank you so much, Prof. Taka, for the question. I would like to say this is the first study that is giving a comprehensive analysis of prevalence of schistosomiasis in Nelson Mandela Bay. However, there was one that was done in 2019 by the Department of Health, which actually showed that there is a 2% prevalence, but they only analyzed one town, which is KwaNobuhle. But from there haven't been any preventive measures or control methods that have been done in the municipality. So we are hoping that with the results that we got from this project, it can actually be a precursor to some control measures that can actually control the transmission of schistosomiasis.
Thank you so much for the question, Prof. Taka. Delegates,
Thank you.
One more question. We've got about a minute to spare. Please feel free. Someone online, someone on the floor. Going once, going twice. Thank you so much. see there's a trend for schistosomiasis. We've got another one coming up, Mr. Campbell, who's going to look at the role of environmental factors, vegetation type, and community knowledge, attitude, and practices on schistosomiasis, intermediate host snails distribution in the Nelson Mandela Bay water bodies. We'll give you 30 seconds to set up, sir. Mr. Campbell, the floor is yours, sir.
Thank you. Good morning, everyone. My name is Prince, and I'll be presenting on my study. The title is already the chair has said, the role of environmental factors, vegetation type, and community knowledge, attitude, and practices on schistosomiasis intermediate host snails distribution in the Nelson Mandela Bay water bodies. My study was supervised by our Prof. Prof. Paula, co-supervised by Prof. Janine Adams and Dr. Melusi. Due to time constraints and everything, I actually like presenting after Ms. Vera here because we're doing the same study. So she allows me to skip some of the introductions and actually save time. So what I'm going to be touching on is the introduction, the study aim, research objectives, the methods, results, conclusion, and okay, maybe the references and so on. So as I said, I'm not going to touch more on the introduction. I'm just going to just jump a bit to the life cycle. In some of the factors that Ms. Vera has spoken about, in terms of like schistosomiasis, we also have environmental factors and climatic. Environmental factors and climatic conditions can actually also play a role in terms of like the transmission of schistosomiasis. So if you can see here, life cycle, just to touch on it a bit, just gonna scroll through. You can see on the right, it's showing the human. So basically in this transmission, this is what's happening inside the human body. And then you have the one that is happening on the water. So basically this is taking us back to the triad, the epidemiological triad, where you have your host, you have your environment, and then you have your agent. And then in the context of this study, our host it can be the human, which is the definitive host, and you also have the intermediate host, which is the snails. So basically, that's where the parasite grows. And then you have the environment. So the environment may include your water bodies and the other factors that you find in this water, such as the physical chemical properties, can actually also be the vegetations and so on. So the freshwater snails that we're talking about that actually transmit the disease. So basically, for a lot of people, when you talk about snails, you might think about these big snails and so on. So I actually showed you just a picture here, as you can see. I have a picture of the snail. I'm not sure how I can. Oh, okay, yes. So you can see here, I just put a picture of the snails, and then I just wanted to show colleagues how small these snails are actually. You can actually go to the water bodies and you may not even actually come across or see these snails. It's not the house snails, the common house snails that are a bit bigger. So most of the snails that transmit the disease, or the ones that are of focus, it's the Biamphilaria and the Pulinus one. So basically this spiral one, it's the Biamphilaria one, which transmit the Schistosoma mansani, the intestinal one. And then you also have the other one, which is the Pulinus snail. So basically, it's the ones that we're looking for when we are actually going and collecting snails in these water bodies, because these ones are the ones that actually transmit the disease. So the aim of the study was just to understand the role played by factors such as the physical chemical properties, vegetation type, and community knowledge, attitude, and practices on the distribution and habitat preference of the intermediate host snails in the reported areas within the Nelson Mandela Bay. So basically, Karieka and Guanobuhle are places where there were reports previously of infection in terms of like schistosomiasis. So looking at the research objectives, the first one was to determine and compare the water physical-chemical properties of the select water bodies. And then the second objective was to examine the influence of vegetation profile and habitat preference of schistosomiasis intermediate host snails in the water bodies. And then also to determine the environmental condition of water bodies and to assess the community knowledge, attitude, and practices regarding the schistosomiasis using a questionnaire. So looking at the research methods, this was a quantitative cross-sectional study. And as I said, it was conducted in Kareha or Wanobuhle. And the study was actually investigated in 3 phases. Just to take you through the phases a bit. As you can see, phase 1, we actually determined the physicochemical properties. And in phase 2, we actually determined the vegetation type, as well as the distribution and habitat preference. And then phase 3 was actually the CAP survey, where it was a pre and post intervention. So basically meaning that we would do the interviews first, and then after that we would implement an educational intervention and then come back after a period that we envisaged there, and then redo the questions and just to see the difference between their knowledge and so on, and then as you can see, analysis of results and so on. So this is just a map of the study area, as you can see here. And then these are the study points, the sampling points. They actually represent the water bodies. As you can see here, this is like a stream, maybe it's like a river and so on. So it happened both in Utenek and actually Wanobuhle. So Wanobuhle, for those that do not know, is actually in the outskirts of Kariega. So just looking at the data collection, phase 1 and phase 2 were actually done simultaneously. That is why I actually did this diagram, just to show that when we collected the physicochemical properties and we were sampling for the snails and vegetation, we actually did it at the same time because we did it in the water bodies, so we didn't really have to. So yeah, so 8 water bodies were actually sampled. The sampling took place over a 9-month period, and the time was between 8 a.m. to 3 o'clock, 3:30. So in most studies, usually they actually do the sampling actually early in the morning, given considering the conditions for the snails, because maybe sometimes when it's afternoon, the snails, you may not find them. But we actually did like a pilot study to actually check the effect of that, to see if the snails were actually hiding at night, because we actually had a lot of water bodies to sample, so we couldn't actually do something from 6 o'clock to 8 o'clock. So that's why the time was actually took us a bit long. And then the sampling took about 15 minutes per site. So the snail collection was at 30 minutes. Measuring the physicochemical properties was like 15 minutes, and then the vegetation coverage would actually just take a picture. Okay, so this is just one of the sampling techniques and the instruments. So basically, we use plastic containers to collect the water samples via just dipping. And then the measurements were done using handheld meters. We used the Bante 900P, the Macherini Hao, and the hardness meter. So I guess here you can just see some of the instruments. And then field observations were carried out to determine the environmental conditions. So basically in all the water bodies where we would just look at, as you can see a plastic here, you can see some algal bloom here. So those are just some of the observations that we would do for each every water body. And then for the snail sampling, we actually used a standard 300 micrometer mesh scoop net on a metal frame, as you can see here. And then we would collect the snails in bottles containing the water from that same water body, and then we would later identify these snails according to a shell morphology using the field guide to African freshwater snails. And then, as I was saying, we also took these photographs from a single vantage point. So basically, for each and every water body, we would just have one point where we would actually always take these pictures, so that we can be able to determine the difference in terms of like the vegetation coverage, to see that for every month, the growth of vegetation, how it was. And then we'd also collect the plants and we would take them to the science department for the identification process to just tell us the type of plants that they were. And then in terms of like the CAP, the interviews, the participants in terms of like the inclusion criteria, we looked at other community members that were between the ages 18 to 65 due to the fact that they can consent. And also we consider those who are living nearby water bodies, because they are the ones that are more likely to be affected by the disease. So this was a pre-post intervention study in 2 phases, and the participants were interviewed face-to-face using a structured questionnaire, and a phone was used to actually conduct the interviews, because we used the Question Pro program. Participants consented by signing a form, and information leaflets were used actually for the intervention phase. And then the post-test took place 3 months after the intervention, to allow the participants to assimilate this information and so that people do not actually cram, because if you can teach some people something and then come back quicker, they are more likely to give you the correct answers. And then the questionnaire was in sections, and it contained close-ended questions about schistosomiasis cause, transmission, clinical symptoms, prevention, and control. So just looking for the CAP one, just looking at first, we enrolled 399 participants. So the pre-interviews, we had 399 people, including the educational intervention, because we would actually do the educational intervention after these pre-interviews. And then after a 3-month period, when we went back, we were able to get actually 380 participants. 19 of them were lost due to follow-up. When we went there, some of them, they had moved, they were no longer there, and some of them were no longer interested. So we ended up using these 380 as the final participants in terms of like the analysis of our study. So the study, we used statistical tool, R software version 4.2 to do the analysis, and then descriptive statistics were used and inferential statistics were used for all the phases. So I don't really need to touch more on this. And then just looking at the overall results in terms of like the physical chemical properties, dissolved oxygen and temperature, as you can see here, the ones that are appearing in orange, they represent the dry, because actually sampling took place, we actually considered the season for the sampling. So the wet took place, so sampling took place during the wet season and the dry season. So dissolved oxygen, as we know, these snails are actually pulmonate, so which means that they breathe oxygen and stuff. So it was very, very important. So oxygen is actually an indicator as to whether the water bodies can be contaminated and so on. So it was a very important parameter to actually check. As you can see here, we found that during dry season, the average dissolved oxygen was 4.5, and then during wet was 5.3. And then for temperature, it was 16.7 during dry, and then 23.4. So actually, according to literature, the optimum temperature for snail growth is actually 27 degrees. So, but snails, according to literature as well, they can actually tolerate temperatures going down to 15. So if you can check our the averages that we actually got, they actually fall between that, so that it means that snails could actually tolerate these temperatures, but these temperatures were not optimum enough for the snail to actually grow as much as they would want, as well as the oxygen. So which means that if you have more oxygen, you're more likely to have more snails. So this oxygen, as much as it was a bit low, but it was still, according to literature, within the limits for snails to actually grow. And then just looking at it's just a bit of a correlation. So I'm not going to touch more on it, but basically what we found was that in terms of like turbidity, we found that there was no correlation observed between the snails and the physicochemical property turbidity, which means that turbidity did not really have an effect on the snails. Whether it was higher or lower, it actually did not have any effect on the snail numbers. And then there was actually a negative and weak relationship between the snails and the rest of the physicochemical properties, which means that whenever the physicochemical properties would go up, there would be a slight decrease in actually the snails. So just looking at the snail sampling, we actually sampled a total of 844 snails. But I actually highlighted the important ones here because these are different genera and stuff, but the ones that we're looking for which actually transmit the disease is the Bullinas and the Bioinfilaria. And actually total for the Bullinas, we actually got 8, and the Bioinfilaria, we actually got 5. So these results may be one of the pointers as to how or why we have a low prevalence, because if the snails that transmitted disease are low, we would expect to have like a low prevalence. The interesting part is that the snails were only found in rivers. Swartkops, also a river, and Sangap was actually a river in terms of all these type of water bodies. So maybe that's another sign. And then in terms of like the vegetation coverage, another interesting part was that most of the snails were found in places where the vegetation cover was around 20 to 30%. And according to literature, actually, most snails, they actually grow in places where the vegetation is actually minimal. In terms of like the correlation, so we also found that there was a negative and very weak relationship between the snails and the vegetation coverage. As you can see here, most of the snails, they were between the coverage 20 and 10. As the coverage was going up, you can see here there was low number of snails, so which means that the more there was vegetation, the less likely you would find snails in those places. And then in terms of like the CAP, a total of 380 participants, consisting of 51% which were males and 48.7% were females. Majority of the participants were aged between 18 to 35 and were single. and they belong to the African Racial Group. So most participants had attained secondary school level of education and were unemployed. And about 145 have been living in the community for 11 to 20 years, and 337 were actually aware of the nearby water body. So in terms of the question, the awareness of the disease, we actually found that about only 8.7% of the participants were actually aware of schistosomiasis or knew what schistosomiasis was. And in terms of like the route of transmission, as we know that the disease actually found in terms of like being in direct contact with the water bodies, we actually found that during the pre-test, most people, they actually did not know or could not actually give out the correct answer in terms of transmission route. But post-test, you can see there was actually, the numbers actually increased. Same as to the question as to who can contract the disease. Actually, everyone can contract the disease, even though it affects children the most because of their temperament behavior. But we found that during the pre-test, most people couldn't really give the correct answer. But after the intervention, people could now know that it's actually everyone who can contract the disease. In terms of their attitudes, they already had a good attitude, but after the intervention, the attitude increased. Same as to seeking medical care, it showed that before the intervention, about 75%, they had a positive attitude, but after the intervention, at least we tried to improve that. And lastly, in terms of like the practices, we can see that most of the participants pre-test, 16.3%, they actually made contact with water bodies. But after the intervention, less of them actually did that. Actually, same applies to peeing in the water, because that's how you keep the transmission cycle going. If you pee in the water, because you introduce the eggs again. But after the intervention, it actually improved. And then in terms of the conclusion, we only found that a few intermediate host snails, which is stating were found in the water bodies after 9 months of sampling, and intermediate host snails were only found in rivers, like I said. And the temperatures throughout the year did not seem favorable for the Pulinas and Biomphalaria, and snails from the Pfizer genera were found in abundance and seem to adapt well in harsh conditions. And actually, Pfizer snails could be used as a biological control measure in the future. And there are studies that have done it before. And Capon schistosomiasis in Kariaka and Guanobutle increased significantly. And I would just want to say that I want to thank the Water Research Commission for funding the project. And I would also want to extend my gratitude to Olive and Marilyn for the support during the data collection. Thank you.
Thank you so much, Mr. Campbell, a man that appreciates time. Colleagues, to the floor. A question to Mr. Campbell.
Okay, so I just want to know, what are the symptoms in children? How can you tell that they actually contracted the snail? And yeah, thank you.
Oh, okay. Thank you. I actually jumped the introduction, so that's why I missed battling, because I thought my colleague here, Marilyn, is touched on that. So basically, one of the symptoms, some of the symptoms, they actually, you can have like rash, but if you see like rash, because if the child was playing in the water body, so wherever the snail actually penetrated, they would leave these reddish spots, and the person would have rash. But the one symptoms that are defining is actually to have blood in urine or blood in the stool, like hematuria and so on. Those are actually the defining symptoms, because you can also have diarrhea, but you may never know. Diarrhea may be caused by different things. You may have your headache, you may have your muscle pains. So some of those common symptoms are there, but the main ones that you actually want to look for is actually the ones that have to do with like the blood in it and so on. So thank you.
Another question to the floor?
Yes, of interest.
Sorry, Prof. Taka. I'm going to come back to the, I'll come back to the colleagues online. I first want to give the opportunity to the ones that are in person, and then we'll open it to the attendees online. Just give us a second, please.
Thank you so much, Prince, for the presentation. My question was, when you were collecting the snails, the ones that you got, the Bolinas and Biomphalaria, did you actually try and shed them to see if they are shedding Sikari? Because that's
Thank you, Mary. Yes, I actually did try to shed their Sikara. So for the other colleagues here, basically to shed their Sikara is that, so these snails are in fact, so as you remember in the life cycle, we said that the parasite, after you defecate in the water, it's going to look for the snails. So it wants to develop in the snails, right? After developing in the snails, then it will shed this Sarkaria out. So this Sarkaria is this infective stage. It's the one that actually infects humans. So basically, when we collect these snails, the ones that can actually transmit the disease, what we do is that we shed the Sarkaria. Basically, it's something that you can do in the lab or indoors. So you can put the snails in containers, specific containers, and then you actually expose them to light for a particular period, and then you put them into the darkness, and then you put them into light again. It's actually like a procedure. So that allows us to see if the snails were actually infected, because if you do that process of exposing them to light and then dark and then light, then they will actually shed these Sarkaria, the ones that are actually infective, and then you will see if these snails were actually having this schistosoma in it and stuff. So yes, I did that. I actually had 13 snails that actually transmit the disease, but I actually did not find any Sarkaria in those snails. Thank you.
Prof. Tucker, I'm going to hand over to you.
Okay, thank you, Mr. Campbell. It's so interesting about the environment, especially where you stated that as the vegetation thickens or gets increased, the number of the vectors is reduced. Because it has been one of the issues to look at the type of vegetation which is in the water contact points, which can predict whether the vector is also existing. What should you relate to that when the vegetation gets intense, the vector, the number of vectors also get reduced, which means these vectors want somewhere where it is open and there's less vegetation. What could be the implication of that as far as the environment is concerned? Because I thought intense vegetation, then the vector will attach to that vegetation. Thank you.
Thanks, Doc. I guess in terms of that question, it also has to do with the type of vegetation, not just like the cover of the vegetation. Like for instance, I just didn't touch on it because of the time. So some of the vegetations that we actually found were the common water hyacinth. I'm not sure if I'm saying the word correct. Maybe the ones from the science department would correct me. So basically, some of the vegetation that we found were actually alien invasive plants, which are actually not edible to these species, because you also need to remember that the reason why we're looking at this vegetation is because these snails, they actually eat this vegetation. So we actually found that sometimes in these water bodies, as much as in common knowledge, the more vegetation, the more snails they're supposed to be, because that means that it's more food. But sometimes you can have more vegetation, but if these plants are actually not the ones that are edible to these snails, then that can actually have the opposite effect. So I guess in our study, because we actually found a lot of these invasive plants that were actually there, that's one of the reasons why they were actually found in places where there was less vegetation. I'm not sure if I've answered your question, Prof.
Yeah, I think we have done, because of in not being part of the food chain of the vectors. I mean, maybe that's the reason. Okay, thank you.
Thanks, Prof.
Mr. Gamble, thank you so much for your presentation, sir. Colleagues, please give him a hand. Before we move on to the next speaker, I think we've done well. We're pretty much halfway for session one. So I'm going to give you guys 1 minute to stretch a leg if you want to do anything, so that we can give equal attention to the following 3 speakers, and thereafter we will break for tea. So take your minute, step away from your laptop, do what you want to do. Please come back in a minute. I will reconvene. To the colleagues online, I will also grab your attention as well. And then in the meantime, we'll ask Mr. Ntunja to set himself up, and then we can start the moment everybody's back. Thank you so much. All right, colleagues, welcome back. Our next speaker, Mr. Ntunja, is going to look at the impact of an educational intervention on hygiene knowledge and practices among municipal waste and sanitation workers in the Nelson Mandela Bay Metro. Mr. Ntunja, the floor is yours, sir.
Okay, thank you so much. Good morning, everyone. My name is Ali Ntunja. So I'm going to be presenting on the impact of an educational intervention on hygiene knowledge and practices among municipal waste and sanitation workers. And that was supervised by Prof. Paula, co-supervised by Dr. Velma and Mrs. June Terry. So just take a quick tour, comes to the background of the study. So who are municipal waste and sanitation workers? I think we all know those are garbage workers, garbage collectors. So they are playing a huge role in the sanitation chain, meaning that where the waste is being collected, transportation of waste, and up to waste dumping site. We might not recognize or we might be ignorant the role they are playing, but those guys, they're playing a huge role up until your waste is not collected in front of your yard. So that's when you're gonna realize, but then they are playing a huge role. So which includes light train cleaners, street sweepers, and waste transporters. But then as much as they're playing a huge role in our in keeping our environment clean and a safe environment for all, but then due to a lack of hygiene knowledge and practices and educational programs they receive regarding hygiene, they are widely exposed to a myriad of hazards like hygiene-related diseases, including leptospirosis, diarrhea, cholera, and various other diseases because of the lack of educational program they received. So, which increases their risk of mortality to up to 40%. That's a huge amount. So, coming to the study rationale, as I've mentioned, there's a need to train those workers regarding hygiene. And in the Bay, there's no similar studies that were conducted among municipal waste and sanitation workers. And the study provided more in-depth understanding of the hygiene knowledge and practices of those studied participants, and also to offer mitigation strategies to curb the spread of hygiene-related diseases. So coming to the objective of the study, so the study aimed to assess the hygiene knowledge and practices of municipal waste and sanitation workers, pre-educational intervention, and also to implement an educational intervention on hygiene and to evaluate the impact that educational intervention had on the hygiene knowledge and practices post-intervention. So coming to the study background, study area. So the study was conducted in Nelson Mandela Bay. As you can see there, those study sites where the participants normally gather, waste depots, and wastewater treatment plants. So we had 5 waste depots where the participants normally gather, and 6 wastewater treatment plants. So the study was a quasi-similar study design, one group pre and post-intervention phase. So there was no control arm in this study. One group of participants was used to evaluate the impact of educational intervention. So as I've said, the study was conducted among municipal waste and sanitation workers, and convenience sampling was used to select the participants who met the inclusion criteria. So the inclusion criteria basically was all the participants were available during data collection, and those who were willing to participate, and those who can understand English and speak Xhosa, since the researcher is a Xhosa native speaker, so we can also translate the tools that were used from English to speak Xhosa, so try to accommodate all the participants. And 244 participants were enrolled for participation in the during the pre-test, and ended up with having 201 participants for the post-test. So this is a schematic flow diagram of data collection process. So as you can see, we had 3 phases. The first phase, it was a pre-intervention phase whereby the structured questionnaire was used to collect the data from the participants. And those structured questionnaires were adapted from the existing literature. So following after participants completed the questionnaire, immediately we commenced with the intervention phase, whereby the Microsoft PowerPoint presentation, both English and Xhosa, and also the use of flyers and posters to reinforce that information. And we also put it post in their waste collection trucks and respective lockers, so that to reinforce that information. As you can see them, once we finish the intervention phase, we allow the period gap of 2 months, so that to avoid courtesy bias, whereby the participant will tell us what we want to hear. So we allow that information so that we could get the true reflection of the hygiene knowledge and practices, rather than like doing the post-test immediately after the intervention, because they will tell you what you want to hear. So we allow that period gap of 2 months. And During the post-test, we follow the very same data collection process as the pre-intervention phase. The structured questionnaire was used, and also we had losses of 43 participants due to they're not willing to participate and the location of participants from one depot to another depot, etc. So moving, those are the pictures that we captured during data collection process during the data collection phase, whereby you see the pre-organized venue and researcher monitoring the data collection process. Here's the flyer posters put up in the risk collection tracks, etc. So coming to data analysis, data was captured in a question pro survey, and the descriptive and financial statistics was used to analyze the study and chi-square test. Mean of pre and post intervention test scores were also compared using dependent t-test. So coming to ethical consideration, for sure the study was conducted in accordance with the Research Ethics Committee of Nelson Mandela University, and it was also under the in accordance of three Belmont Board principles. As you can see, respect of participants, so participants were informed their rights and that the participation was completely voluntary, no one was forced to participate. And if they're willing to participate, they were free to withdraw from the study. And the participants were protected from exploitation. So coming to justice, confidence sampling was used so that the participant can have a equal chance of being selected during the study. And the questionnaire information pertaining to the education intervention, the very same questionnaires were used, English and Xhosa. So coming to the results, demographic profile of the participants. So as you can see, male participants were more than female participants. So of which this could be due to the nature of their work. As you know that those guys, they need to climb the waste collection trucks, needs more physically strong individual. So that's why we had more males than females, because as I said, the nature of the work. So coming to the institutional level, as you can see there, majority of the participants, 57%, okay, only 9% of the participants acquired teacher level of education, and 57% of them were below grade 12. So it clearly shows that the educational level of the participant is very low. Okay. I'm not sure. I think the can you skip the slide? Oh, okay, it works again. Okay, coming to hygiene-related knowledge. So the participants were asked if they ever heard of hygiene-related diseases. So as you can see here, the majority of the participants, 47%, they say they never heard of hygiene-related diseases. And only 39%, which is 95 participants, they say they heard of hygiene-related disease. But then, even that 39, in that 95 participants, out of that 95, only 29 participants who have heard of hygiene-related disease through educational programs. So as I've said, there's a lack of educational programs they received. So moving quickly, participants were also asked if diarrhea and cholera are hygiene-related diseases. As you can see, the participants said in the pre-test, 73% of them, they said it's true, which that was a desirable response. And then the post-test, 87%, they answered that correctly with the improvement rate of 14%. However, as much as the participants were aware that diarrhea and cholera are hygiene-related diseases, but if you're looking to the clinical signs or clinical symptoms of those diseases, the knowledge of the participants was poor. So if you look at here pre-test, when they ask if blindness is the most common sign of diarrhea. So the majority of them, they said yes. So they believe that if you're blind, you possibly have diarrhea or something. So you can see them, they said 43%, they said, yeah, that's true. However, during the post-test, as you can see now, the participants they answered that correctly. They said false, 74%. So there was an improvement of 41% on that one. So coming to understand the knowledge regarding the preventative measures to prevent the spread of those hygiene-related diseases. As you can see there, the participants were asked if hand hygiene and hygiene-related diseases they do not relate. So the correct answer there was false. They do relate. So, but during the pre-test, you can see there the participants, they said it's true, majority of them. They answered that incorrectly. But then the post-test, as you can see, the participant understood that hand hygiene and hygiene-related diseases, they do relate. So it goes back to the fact that, as I've said, that as much as they know that as much as they're aware that diarrhea and cholera hygiene-related disease, but when it comes to the clinical symptoms and comes to the preventative measures as well, it was lacking, like they had lack of knowledge on that one. So move further, rubbing your hands together is more effective against microorganisms than hand hygiene. So during the pre-test, as you can see there, participant, they said 34%. They said, yes, rubbing hands is more effective than hand hygiene. And then, but then post-test, as you can see that they answered that correctly, the improvement rate of. So let me just move quickly. Coming to the importance of light trial. Also, the participants were asked if the importance of lifetime use is privacy only. So as you can see during the pre-test, the participants, they said it's true. So they believe that the only reason why they are using the pollution facilities is only for privacy. So 67% of them. But then post-intervention phase, as you can see, the answer that correct. Now they understand that lifetime use is also for environmental hygiene as well, to keep our environment clean and safe. So regarding the disposal of waste, the participant, they showed a positive knowledge on that one, because it clearly shows that they understand why they are collecting waste. If they are picking up rubbish on the floor, they know that we want to keep the environment clean. So they understand the scope of work, they understand why they are doing what they are doing. So as you can see, the improper waste disposal is a threat to environmental hygiene. So participant, they say true. So as I've said, like they answered that correctly, 76%. Post intervention, the improvement rate of 13%. So come the results of hygiene-related practices. So those results were also influenced by a couple of factors, like accessibility to pollution facilities, the condition of locals, and various other factors. But then we're just going to touch on that one. So if you can see here, participants were asked if they wear gloves when handling waste. So most of them, they said yes. So which is a good practice, positive practice on that one. So when it comes to the disposal of PPE, so as you can see, a risky behavior was observed. So as much as the participants, they are wearing gloves, but then it means that they were just given gloves, that you need to wear gloves when you are handling waste, without being taught like why it's important, the theory behind of wearing gloves in mitigating or to curb the transmission of hygiene-related disease. So they are just given gloves without any knowledge why it's important to wear those gloves. As you can see here, how to dispose them. As you can see, they said 54% of them, they say they dispose gloves and mask in the river after use. So they're just disposing it. They're just showing it. So the participant will ask if you are tolerating in an open space sometimes. So the majority of them, they said yes during the pre-test. It goes with factor like because the participants, when it comes to when they're doing their task, they are only on the depot for only 1 hour, from 5 a.m. to 6 a.m. to sign for their presence at work, and then after that they go to the streets, so they don't have access to pollution facilities, so they are pushed to have that risky behavior among the participants. That's why you see here, to 4% they say they use open space to relieve themselves. So, but then regardless of the consequence of the challenges, but you see post-test, the participants, 81% of them, they refrain from that risky behavior, the improvement rate of 40%. So if the participant were asked to do, if they remove clothes when sweeping or collecting waste immediately when they are done, so the majority of them, they said 41%, they said they don't. So it goes against the condition of the locals as well, because no one's gonna be comfortable to leave his personal stuff, personal belongings in a locker that is not in good condition. So those are one of the factors that influenced their practice. So, but then post-intervention phase, 75% of them, they said, yes, they try to remove their clothes immediately when they're done. Okay, so it further, we asked participants if they do smoke or eat when they're working. So the majority of them, they said yes. So it goes to the access to rest areas whereby they have their lunch. So those guys, they're eating while they are working. So they don't have time to, they don't even have a venue to whereby to have a rest area to have their lunch. So they're pushed to eat or smoke while they are working, while they're handling waste, of which it also is a risk to, they can, it's one of the risks to transmit those hygiene-related diseases. So I bath after coming back from work. Only 28% of them, they said yes, they bath. But then that number might seem like it's a small percentage, but then it's a huge when it comes to the transmission. Look at the transmission of those hygiene-related diseases. If 28% of them, they don't bath. Remember, those guys, they have families back home, and they're using public transport as well with those coveralls as well. So when it comes to the transmission of hygiene-related diseases, that's not a positive behavior. So we also had a systematic review that was conducted. Also a systematic review that was conducted on one of the objectives to evaluate the impact of educational intervention on sanitation workers at global level. So we realized that there are predictor factors like age and educational level, background, etc. But then there were contradictory findings on that one. So we further did a multivariable linear regression analysis to check which demographic characteristics that influenced the efficacy of the implemented intervention program. So we found that the working report significantly influenced the results of the post-intervention phase, age, the race, and hygiene-related hygiene educational background. So coming to the conclusion, the hygiene knowledge and practices of municipal waste sanitation workers increased significantly post-intervention program. And also the findings support the notion that educational program focus on hygiene serve as a vital tool in enhancing the knowledge and practices of sanitation workers. And by doing so, these programs contribute to the prevention of hygiene-related infections as fostering healthier and safer environment for all. So I'd like to acknowledge Mr. Prince and Ms. Ferrer for their support throughout this journey, and Water Research Commission for the funding. Thank you so much.
Thank you, Mr. Ndunja. Wonderful presentation. Colleagues on the floor, can I please get a question? Colleagues online, as soon as the questions on the floor are addressed, then I will give you an opportunity.
A wonderful presentation, sir. I just want to know the name. I'm coming across this name for the first time, the Municipal Waste Sanitation Workers. So are they affiliated or part of the municipality programs? Why are they? And I know you said they're garbage workers, which is an informal term. And then now there's a municipal sanitation workers. Just interested there.
So I'm not sure if I heard you correctly. So we are asking if the categories of those garbage workers, like maybe. Okay, so can you repeat your question, please?
Okay.
Okay.
So what I'm asking, I'm interested. Yeah? This is very good for me to know that there are also municipal waste sanitation workers. And your introduction is highlighting that these are garbage workers, which is they form part of the informal working sector. Okay? So what I wanted to know is, are they paid by municipality, or this is just the terminology supported by the literature, the one waste, what?
Okay, so basically the word is supported by the literature, and those categories, as you can see there, these are municipal waste, so, and sanitation workers. So we know, as you know, as I've said that they're playing a role in the sanitation chain, basically. from where the waste is being transported, collected and transported up to a waste disposal site. So that wording is also supported by the literature, and also the municipal waste authority, they also gave us clarity on the word that we used as the municipal waste and sanitation workers. Not sure if I answered that correctly. They are employed by the municipality. They are employed by the municipality. But then when it comes to the educational program, as much as they're employed by municipality, but then they are regarded as informal workers. So it means that they are just, if you see someone there, come, the municipality gonna pay, we want you to do this job. So as much as they are informal workers, but they're employed by the municipality.
Yeah, look, I think it's very good because yesterday I was presenting exactly on, because I did, my PhD was on the waste pickers in the rural Eastern Cape.
Mm-hmm.
So what I found was the fact that municipalities are not recognizing the sector, especially of the waste pickers. So now this is interesting, especially in is it Buffalo City or what? What
No, it's Nelson Mandela.
Nelson Mandela. So it's very interesting to find out that at least there's form of recognition or programs to realize their work as informal workers.
Yeah.
Okay. No, I just want to ask quickly, is it part of EPWP? That is are they part of that, or they just employed by the municipality? There's expanded public works program.
Okay.
Are they part of that?
You
know, those people who are collecting what is this? Yeah, garbage and cleaning the streets as part of EPWP.
Okay. So, but I'm not sure specifically for that one, but then we can assure that they're employed by the municipality. So I don't want to, I'm not sure about that clearly, yeah.
Thank you for the two questions on the floor. One more question, and then I will give an opportunity to the colleagues online.
Thank you so much, Mr. Ntunja, for the presentation. My question was, despite the cholera and diarrhea, did you get any reports on other diseases that the municipal workers are reporting to be sick with?
Yeah. So according to the literature, hepatitis A and hepatitis B was specifically for municipal waste and sanitation workers was the prevalent disease among municipal waste and sanitation workers. So it's just that I didn't touch on the background, but then according to the literature, hepatitis A is prevalent among this group of participants. One of them.
Thank you for the questions on the floor. Colleagues online, anyone with a question, please feel free to unmute yourself. Going once, going twice. Thank you very much. Guys, can you please give Mr. Ntunja a round of applause? Okay, our next speaker is Ms. Stinane here. Oh, perfect. I'm going to give you 30 seconds to set up, and then I will introduce you to everyone. All right, colleagues, our next speaker, Ms. Stinane, is going to look at harmonizing worlds, indigenous healing, and psychological well-being in South African rural communities.
Thank you. Good morning, everyone, in the floor and online. As introduced, I'm Tembega Stinane, and I'm going to be presenting today on indigenous healing and psychological well-being. This is the presentation today is just a teeny portion of my bigger PhD project, which is focusing on religious rituals and psychological well-being in the Zionist churches, specifically targeting or looking at their potential benefit. And I've foregrounded this study in the rural areas of the Eastern Cape, particularly because the state of mental health services in the province is quite concerning. If you see the table that is provided there, that's the statistics from 2013, it just shows the number of mental health beds that are available per region in the Eastern Cape within the public health sector. So this would be the number of beds that are allocated to mental health patients in public hospitals. And where I collected my my data, which is in the rural areas of Madedele, it's in the Alfred Nzo region. And if you can see, there's 0. And the nearest bed available for people in those communities will be in OR Tambo, which is in Umtata. And that is around maybe 250 kilometers away from the town. So it is quite concerning, and as a result, it is not surprising that people in those areas, they depend on indigenous healing to address they depend on indigenous healing to address any mental health care concerns. While we acknowledge within the scholarship of psychology the biopsychosocial nature of health and well-being, the role of indigenous knowledge system within psychology has been overlooked. And as a result, we see that the ways in which we produce knowledge and the ways in which we view reality about what constitutes health and what constitutes well-being is mostly dominant using the Eurocentric framework of understanding, which is largely biomedical. And therefore, when it comes to viewing or when it comes to addressing mental health concerns in African context, whose cultural context plays a huge role in how they view health and well-being, there is some form of disparities that we note in those cases. And as a result, if we look at current debates in psychology, if we look at debates of the psychology of relevance, if we look at decolonial scholarship debates, and if we look at African psychology scholarship debates, all those are trying to address the gap that we see in that when it comes to how we view the African person in relation to health and well-being, we need to consider their cultural context. We need to consider the way that they produce knowledge, which has been predominantly an oral history that is passed down from generation to generation. We need to consider how they view their reality, in that their reality is intertwined in the connection between the body, the soul, the environment, and their spiritual dimension. So most research does focus on indigenous healing, but we see that they focus mostly on indigenous healing in the treatment of mental illness. And therefore, this study highlights the use of healing in enhancing well-being. So we're just taking a more of a positive spin into illness. In this presentation, I'll attempt to show the potential benefits that are inherent in the ritual of uKhlambulula in enhancing psychological well-being. And I'm going to be looking at uKhlambulula from a systems theory point of view. So I'm looking at it from an individual's immediate setting through to the broader society. And the focus on uKhlambulula is that it is a ritual that has many other rituals that are also inherent in it. For this study, I had to dip down and conceptualize what psychological well-being would mean for the participants. And as such, we decided on conceptualizing psychological well-being as ukuphila emoyeni, or ukuphila moyeng if you are Mosotho. And it acknowledges umoya as the psyche, so it's psychological. It acknowledges umoya as emotion, so it's mood and affect. As well as acknowledging umoya as the spirit of, or the soul, so umoya is spiritual. And the reason why is because of, number one, the population of this study came from congregants and the clergy from the Zionist churches. And within the church, they use the concept of ukila emoyeni as an indication of how they are doing emotionally, psychologically, as well as spiritually. So in order for us to use a concept that was relative to them, we then conceptualized psychological well-being as upile moyeni. But at the same time, we also acknowledge the interconnectedness of health, in that one may not be psychologically well if they're not emotionally well or spiritually well. We also acknowledge the cosmology of the African worldview that balances the person, their environment, as well as their spiritual dimension. So that is why we went with that conceptualization. If we look at what psychology and the widely used model within psychology that explains psychological well-being, is that it highlights the 5 components of it, which is having autonomy and choice, having a purpose in life, positive relationship with others, personal growth, and self-acceptance. And while that is a widely acceptable and used model within psychology, it creates some bit of problems when it is being applied to African people. And that is mainly because of socio-cultural factors that exist within the African context, and some socio-ecological characteristics. So for example, if we're looking at autonomy and choice, that is more, and personal growth, that is more applicable to people that ascribing to more individualistic cultures, as opposed to relationality, which is more applicable for people that adhering to more collectivist cultural orientations. So again, the holistic of health and well-being also determines what psychological well-being is. Therefore, if we look at personal growth, for example, from Riffin's model, it acknowledges that healing is an individual responsibility, while when you look at African people and their relational view of well-being, you heal yourself so that you heal your community. So healing in this instance is more of a collective responsibility than an individual one. Yeah. So when I looked at rituals, this is not the updated slides, but when I looked at the rituals and the psychological consequences, and I tried to look at rituals as rite of passage. So in this case, they highlight the transitions of a person's life. So in a continuum of birth and death, there's rituals that individuals engage in. And most of those rituals are very communicative in nature. So they kind of prepare individuals for what's to come, and also inform them of specific steps that one may take. So if we take, for example, what can we say? We can, let me just use that example. Between life and death, it is used, for example, in burial or mourning rituals, where the family or the individual, even the community, have to engage on the ritual in order for them to kind of rid themselves of the bad luck that is associated with death. Within the Zionist church, it's also used just after birth, for example, for a new mother, after confinement, the first time they're going back to the church, they have to engage on the ritual of Uklambulula just to realign themselves and almost to bring harmony between themselves and the environment that they are stepping in. So in overall, the uklambulula it's a cleansing ritual in the simplest term, but in a more deeper spiritual dimensions, uklambulula is the process of bringing harmony between yourself, the environment that you live in, as well as the spiritual world. I look at rituals as a sense of meaning in that it provides you with a purpose. It gives certain meaning to what is it that you are doing. I look at rituals as a manner to connect people. So the collective responsibility of rituals. I look at rituals as the transcendent because Zion churches are known as spiritual churches. Their rituals are mostly a way to connect to that which is higher than the self. So the embodiment of umoya in their healing rituals, it kind of highlights that ritual activity goes beyond the physical manifestation. So if you look at something like, for example, in the dance rituals, if you go into trance, that is an experience that cannot be explainable by the objective reality that exists in psychology. So using systems theory, I then collected semi-structured interviews, which seemed to be a bit of problematic in terms of the context where the research was studied in. However, we found that the benefits of uklambulula as a ritual extended from the person through to the broader society. And they incorporate both religious and cultural aspects. And this is because of the ideology of the Zionist church. So the church has successfully merged Christian and African practices into how they conduct their practices. So it is at individual level. It's an observance in church. Every Sunday service, before the start of the church, all church members get to have an opportunity to state whether they are well psychologically, physically, and if they need any form of support. It is also used by, for example, a lot of the priests in the church are spiritual healers. So in terms of their spiritual growth, they normally engage in the process just to realign themselves. And some potential benefits is, of course, receiving healing, forming social support within the church, and some spiritual growth for people that are spiritual healers. And as I've mentioned, the enactment of uklambulula, it adheres to both religious and cultural values and norms. So you'll see that for some people, they use maybe water rituals to conduct uklambulula, and that would mean within the religious realm, it will mean using the holy water as a source of healing. But in terms of cultural, it will be incorporating, for example, some traditional medicines or herbs into the process. And then when you look at it from a meso level, is that it acknowledges that a person's systems are interconnected with each other. And this is where we saw that psychology as a profession and the psychological mental health care system, it creates this division when it comes to people enacting these rituals. So there was kind of a disconnect between what psychology views as a ritual and the importance of cleansing versus what they from the church and as well as the cultural point of view view as the benefit of the ritual. But even at that level, it is enacted to restore harmony, but also the benefit there is a strong social connection amongst people, as well as positive relationship with other people. Because one of the things in the church is that you have to get rid of your burdens so that you don't burden the others in the church, hence going back to the collective nature of healing. And at EXO level, I looked at Uklambulula as a way that as creating a platform for psychology to provide a more cultural responsive intervention into health and well-being, in that if we are to use Uklambulula, for example, in psychology as a concept or as an intervention, it can be more relative to a wider population, but also it acknowledges that people's reality are different and no one worldview is more superior or more dominant than the other. So then it goes back, it now comes to which worlds are we harmonizing? And is it possible to even harmonize those worlds? And how can that be done? So the Zion Church has successfully harmonized the religion and traditional African practices. And they've kind of found a common ground. So I think when I think about harmonizing, I'm thinking that there's some commonality that exists between the worlds. Can we harmonize it? Is it possible? It is definitely possible. If you look at, for example, mindfulness interventions, those stems from the Buddhist religion. And it is something that is being regarded as a psychological modality, but it has its roots from a religion practice. It can be possible that we can't, in our context, we can't harmonize these worlds, but we can acknowledge that they influence each other. In terms of how it can be done, that is something that we're still trying to find out. And hopefully the bigger PhD project will address that. Thank you so much.
Thank you for the presentation, Ms. Srinane. On the floor, actually, let's flip it around. Colleagues online, is there anybody online that has a direct question? You can unmute yourself. Okay, while you gather your thoughts online, colleagues on the floor.
Absolutely love your presentation. I just wanted to know what were some of the challenges that you were experiencing when you collected the data, and especially in the Zionist church, my perception is, very traditional, and you're a young lady.
Yeah, so I think the most challenge was the concept of research itself. This is the villages that I collected data and recruited participants from. They had no prior experience of somebody coming in to collect research. So it was kind of not understanding what is it that I'm doing, these questions that I'm asking, why am I asking the questions? So I had to take a step back and almost reintroduce people to what research is. The only reference they had to research was like filling a questionnaire at the clinic. So that was quite a huge problem. But also, even with recruitment, I had sent my letters to the various churches, and I received no response. It was only when I orally delivered the information that it was received. So that oral tradition came into aspects there. But also as a young female and having to respect the cultural traditions in the rural areas, I could not be the one who's asking to meet the participants. So I used an elder that I trusted to do the information for me. And at that time, when I was collecting my data, I was expecting, so I couldn't just go to anybody's home. I had to have an elder accompany me, especially when I was interviewing like older gentlemen. It's more respectful if there's an elder who speaks on behalf of you, because as much as you're coming in as a researcher, you are still viewed as a child. And therefore, a child does not have a right to request a meeting with an elder. So it was almost viewed as a meeting. And it was really, really difficult. And I think perhaps choosing a methodology or a method more like storytelling would have been much better in this context. And that is something that I realized as I was collecting data, to say that the interview is almost like, why are you asking questions? Why are you questioning us? And not necessarily as that this person is just trying to find information. So, yeah.
Nice question, coupled with an elaborate explanation as well. You seem nervous. You don't have to be nervous. You're doing well. Can I ask for one more question?
Thank you very much. I was listening with interest. I know the challenges around rural areas and such, topics. I just wanted to know, at the end, what is it? Are you going to develop guidelines? Yeah,
yes,
that can be used where in the rural area? I'm interested at the end product.
So the end product is developing guidelines that will guide psychological practitioners in terms of integrating religious practices into interventions. And they are currently under review. So they should be finalized and soon before examination. So there have been guidelines that are developed, and just the highlights of the guidelines are concentrated around the mental health professionals training in terms of them understanding religious practices, as well as how they can be integrated into interventions. They are focused on the use of language, in terms of concepts that are relatable to people, and how we can use language to encourage the integration of religious and cultural practices, as well as the use of the religious leaders as knowledge producers and knowledge carriers in psychological interventions.
Thank you so much. That is all that we have time for this specific presenter. Mr. Zane, thank you very much for your presentation. Colleagues, please give her a round of applause. All right, our final presenter, Dr. Khan, you can come to the front so long, and I'll give you 1 minute to set up. Okay, while we get set up, I will just introduce Dr. Khan's topic. She's going to look at the prevalence and determinants of burnout in medical doctors at public hospitals in Gqeberha, South Africa during the COVID-19 pandemic, a cross-sectional study.
Hi, good morning all. I'd like to thank Prof. Paula and Berthlin for inviting me to present our research this morning. As was said previously, the topic of our research was the prevalence and determinants of burnout amongst medical doctors working at public hospitals in Gqeberha during the COVID-19 pandemic. Burnout, for those of you who are not aware, is defined by the World Health Organization as a syndrome resulting from chronic workplace stress that has not been successfully managed. According to the International Classification of Diseases, it is characterized by 3 dimensions. Firstly, feelings of exhaustion, which may be physical and emotional. Secondly, feelings of increased mental distance or cynicism or negativism towards one's job. And thirdly, feelings of reduced professional efficacy, which may be real or perceived. Prior to COVID-19, the studies showed considerable variability in the burnout prevalence in estimates amongst doctors. They range from 0% to 80.5%. Studies done locally recently in South Africa showed that the burnout prevalence rate was 84% amongst registrars at Witwatersrand. The burnout prevalence rate was 59% amongst medical doctors at 5 KwaZulu-Natal public hospitals. In our institutions here locally in Gqeberha, we found in 2019 that there were increasing numbers of the younger doctors presenting with burnout symptoms to the occupational health unit. These doctors had no previous history of mental health illness. However, in 2020, the COVID-19 pandemic arrived on our steps, and healthcare workers on the front lines faced high workloads, which increased their job stress, making them even more vulnerable to burnout. You know, it's an open secret that historically medical doctors in the Eastern Cape are faced with daily challenges in the workplace. And this was confirmed in 2021 with the Public Protector Report, which revealed systemic deficiencies such as acute staff shortages, inadequate physical infrastructure, insufficient equipment, and insufficient resources like PPE. It is expected that with these increased challenges, doctors would experience increased job stress, thus increasing their risk of burnout in the workplace. However, till then, there had been no published studies regarding the prevalence of burnout in doctors in Gqeberha during the COVID-19 pandemic. Therefore, the aim of our study was to determine the prevalence and the determinants of burnout amongst medical doctors at public hospitals in Gqeberha during the pandemic. Our objectives were threefold. Firstly, to determine the prevalence of burnout within this group. Secondly, to identify individual and occupational factors that may contribute to burnout in doctors, as well as assess the level of resilience in doctors working in our hospitals. And thirdly, to propose preventative interventions at an organizational level that would successfully reduce burnout amongst doctors. Our study was a quantitative, descriptive, cross-sectional study that was performed amongst doctors working at 3 hospitals in Gqeberha, namely Livingston Hospital and Port Elizabeth Provincial Hospital, which together make up Livingston Tertiary Hospital, as well as Dora and Ginza Hospital, which is the regional hospital. The study was conducted during April and May of 2022, which coincides with the 5th wave of the COVID-19 pandemic in South Africa. Self-administered electronic questionnaires were distributed via RedCap. These questionnaires comprised the Oldenburg Burnout Inventory, selected subscales of the NIOSH Generic Job Stress Questionnaire, the Connor-Davidson Resilience Scale, as well as questions related to COVID-19 and workplace interventions. A total of 296 doctors participated out of total of 430 eligible candidates. However, 36 questionnaires were excluded because they were incomplete, and data analysis was only conducted on 260 of the questionnaires. Data collected was analyzed using Stata 15, and the analysis included descriptive statistics, as well as logistic regression analysis, which included unadjusted and adjusted logistic regression for age and gender. Our results showed that the participants were mainly female and young, with 42% within the 20 to 29 year age group. Out of these, 96% of the participants worked full-time and 97% of them worked overtime. With regard to substance use to manage work-related stress, 17% of our participants felt the need to smoke to manage work-related stress, and 20% of our participants felt the need to drink alcohol to manage work-related stress. Mental health conditions were prevalent, with 25% of our participants reporting ever being diagnosed with a mental health condition. 10% of the participants were diagnosed with mental health condition within the last 12 months, and 18% of our participants were currently on treatment for a mental health condition. Using the Oldenburg burnout inventory, 78% was the prevalence of burnout amongst our doctors working in Kebega during the COVID-19 pandemic. An equal number of doctors were exhausted and experienced non-burnout. With respect to job stress, almost half of our participants felt that they were experiencing medium workload. More than a quarter of them felt that they experienced high conflict at work, and a third of our participants reported experiencing high levels of role ambiguity and role conflict. Almost a third experienced low job satisfaction at work, and almost a quarter experienced low support at work. Using the Connor-Davidson Resilience Score, our participants revealed that they experienced, 50% of them experienced medium resilience, while a quarter experienced high resilience and the remainder experienced low resilience. Our study revealed that burnout was significantly associated with being a medical intern or a community service medical officer. Burnout was also significantly associated with being in the lowest band of income. In our study, burnout surprisingly was not significantly associated with socio-demographic factors such as age, gender, or relationship status. It was also not significantly associated with occupational speciality. In the unadjusted analysis, our study revealed that burnout was associated with working overtime. However, when adjusted for age and gender, this association attenuated and burnout was no longer associated with overtime. With regard to substance use, our study showed that burnout was significantly associated with feeling the need to use alcohol to manage work-related stress. It is unclear, due to the cross-sectional nature of our study, whether the alcohol use preceded or followed burnout. However, it may be said that the doctors may have used alcohol as a maladaptive coping mechanism to cope with work stress. Our study also showed that medium and high resilience was protective against burnout. with respect to job stress factors, in our study, we found that burnout was significantly associated with high conflict at work, medium and high role ambiguity and role conflict, as well as being associated significantly with low and medium job satisfaction and low and medium support at work. Interestingly, in our study, burnout was not significantly associated with workload. This is surprising, and we surmise that it may be because of the timing of our study. Our study was conducted during the fifth wave when the increased workloads resulting in the earlier peaks of the pandemic had subsided. With respect to COVID-19, more than half of our participants were infected with COVID-19 and 49% were fully recovered. With respect to workplace interventions, 49% of our participants felt that they were given an adequate supply of PPE, and almost 45% felt that there was adequate implementation of IPC measures in the institutions. It may be said, though, that while some factors related to COVID-19 infection and workplace interventions were associated with burnout, none of the associations were statistically significant in the unadjusted analysis. And from this, it may be suggested that the high levels or the high prevalence of burnout in our institutions had less to do with COVID-19 and were more attributable to the ongoing organizational challenges in our facilities. In many previous studies, poor working conditions and staff shortages have been reported as being contributory to burnout amongst doctors. So it comes at no surprise that in our study, the interventions most supported by participants included employing more staff, improving working conditions, improving equipment supply, and improving management support. Interestingly, the provision of psychological counseling was less supported by our participants. And this may be because psychological debriefing was provided to many of the frontline healthcare workers and doctors in our institutions by the staff psychologists during the previous peaks of the pandemic. Our study had limitations. Recall bias was unavoidable as the data was collected based on participant self-report. Response fatigue was a factor because a previous burnout survey had been done just a few months prior to our survey. The healthy worker effect could have affected the prevalence levels as doctors impaired by burnout may have resigned, leaving the healthier doctors behind, which is actually concerning. The Maslach burnout inventory, which is regarded as the gold standard in the diagnosis of burnout, was not used in the study due to financial costs. And finally, due to the cross-sectional nature of the study, it precluded the evaluation of temporality and causality of the observed associations, since there was simultaneous collection of both exposures and the outcome data. However, the correlation of our results with local and international studies makes it likely that the associations identified in our study may be risk factors contributing to burnout amongst doctors working in our facilities. Recommendations that we decided were important involved a hierarchy of controls at an organizational level. Environmental controls recommended employing more staff, obviously, improving the working conditions, improving equipment supply, and improving management support. Administrative controls would be the developing of clear policies and guidelines to resolve role ambiguity and role conflict at work, and then to mitigate conflict at work by addressing organizational culture and promoting civility as well as reducing the discord amongst doctors, as well as between doctors and other healthcare workers. We also recommend the reevaluation of HR policies regarding overtime to reduce fatigue in our doctors. Finally, we recommend implementation of suitable mental health initiatives as personal protective equipment to reduce occupational stress and burnout by introducing programs addressing coping skills, resilience, self-care, and mindfulness. Finally, it is imperative that doctors are involved at an organizational level in designing these policies and guidelines. So in conclusion, the prevalence of burnout amongst medical doctors in Kebega during the COVID-19 pandemic was high. The factors associated with burnout include conflict at work, role ambiguity, role conflict, job satisfaction, support at work, and resilience. Given the strong associations with job stress factors and burnout, the management and mitigation of burnout should focus on interventional measures implemented at an organizational level. Thank you.
Dr. Khan, thank you so much for your presentation. I'm sure everybody can relate to the pandemic itself. So I'm going to be very disappointed if I don't get 2 questions on the floor. So I would like 2 questions directed at Dr. Khan in the front.
Thanks, Dr. Khan. I enjoyed that a lot. I just wanted to clarify, you said 42% of the respondents were between the ages of 20 and 29. So I would assume those were the interns and the... Yes. So with the findings, you also said that role ambiguity, role conflict were some of the challenges that they experienced. Do you think it could be related to the stage, the life stage that the person is in, because they are probably newly graduated and they have now, and they are in a work environment and they're experiencing that? Could that also be?
Yes, I thank you for the question.
Just another one. Sorry that I'm asking so many questions, but then do you think that the results would then be different if we exclude, if it's possible, this age group and we then just focus on more experienced practitioners?
Thank you for both questions. Yes, I do agree. I have, in my experience, found that the interns and the community service medical doctors are less experienced, and they also find it difficult to make the transition from medical school to actually being employees in a workplace. It is a challenge that some of them master. However, others have difficulty making that transition. So I agree with you, yes. However, we also find that in our institutions, there is a problem with role ambiguity. Due to the staff shortages, the doctors often have to take over the roles of maybe being porters or being nurses when there aren't enough staff available for those jobs. So I think, yes, the transition, some of the doctors do find difficult, especially if they're coming straight from university and haven't had part-time jobs to acclimatize them to the workplace. The second question was relating to whether or not if we removed the younger doctors. In my experience, I would say no. I feel that even if the younger doctors are removed, the organizational challenges remain, and even our experienced doctors are now finding it difficult to cope with that due to the chronicity of these challenges that just don't seem to be resolved at a higher level.
Thank you for the question. Do we have a follow-up question on the floor? And then I will come to the attendees online. Doc, perhaps an observation from I think you mentioned that 74% of the participants were female. Yes? Why do you think majority of the doctors included in your study were female? Does that boil down to the vast majority of doctors across the selected 3 hospitals are female, or is there a perception difference between male and female for wanting to form part of your study?
I think we have to agree that there has been a feminization of medicine and the study of medicine. I mean, there has been active recruitment of female doctors to maybe reduce the gender bias in our workplace. So perhaps that is a reasonable explanation. It may also be that female doctors face a higher burden due to the stress that they have not only at work, but stress in their home lives. And that imbalance of work, life, and balance may be resulting in the female doctors perhaps experiencing more burnout, thus being more willing to complete a questionnaire regarding burnout when they're already short-staffed and don't have time for anything else.
Thank you, Doc. Another question?
Thank you so much, Dr. Ken, for that very insightful presentation. Just wondering, you did mention your study area is amongst the tertiary hospitals, the public hospitals. So out of curiosity, just wanted to know, whereas it may be obvious that the organizational parameters might actually change if it's in a private setting, but when it comes to the attributes related to the medical doctors or the healthcare workers in that private setting, do you think that the burnout would be same or less, or what do you think based on literature?
I think the literature does speak to that. Obviously, the organizational challenges in the public healthcare sector are vast and numerous. However, we have found that burnout is not only caused by organizational challenges. There is an individual or host factor that is responsible. So doctors in the private setting, even though they may not have as many organizational challenges as doctors in the public healthcare sector have, they still may find it difficult to balance the work-life area of their lives. They may also find difficulty in adjusting when they leave from public sector, where all of our doctors are trained, and go into the private sector as well. But on the whole, the research shows that doctors in the private sector have less burnout than the doctors in the public health sector. Studies were done amongst anesthetists in both the private sector as well as the public sector. Studies were also done amongst orthopedic surgeons in the private sector and the public health sector. And both of those studies done locally showed that the levels of burnout amongst private doctors or doctors working in private was less than that of the doctors working in our public health sectors.
Thank you so much, Doc. We have time for one more question online. Anyone? Please feel free to unmute yourself. Going once? Thank you so much. Thank you so much, Dr. Khan. Round of applause for Dr. Khan, please. Delegates, this brings us to the end of our first session. Thank you so much for your interaction, for your participation. I think just on a parting note, could we perhaps have a round of applause for all the speakers? And then we'll follow that up with a round of applause for all the support that you've received. So either the promoters, the supervisors, be it in person and online. And then could you give me a round of applause as well? Thank you. All right, colleagues, we're going to break for tea. That's going to be a 15-minute session. And then session 2 will be commenced with Dr. Venter. So enjoy your tea, stretch a leg, and then come back so that you can interact on the same level or even more compared to the first session. Thank you.